Hi friends, good evening. I'm Dr. Ashutosh, and today we are going to talk about normal anatomical sort of variations that we can identify in the fetal brain. We identified it to be a normal variant, and therefore there is hardly anything to get worried of. So one of the commonest sort of fluid-filled cystic spaces in the brain, which is usually midline, are an arachnoid cyst. So probably we have had a few cases of an arachnoid cyst and which we identify to be sort of a normal variant. We hardly get worried about. They're usually small. They should not be at a critical junction, and they usually get resolved over the period of time. We hardly don't get bothered about and worried about these arachnoid cysts. Second is a cavum vergae. So, meaning thereby that many times we identified a very very important landmark as far as the fetal brain is concerned, which is called as a cavum septum pellucidum. And so the normal fluid-filled cystic space can be identified just posterior to the CSP, and which is called as an cavum vergae, and this could be even a continuation of this CSP, in which we can have some fluid between these two septi, right? And we can have a variable a variable sort of an length to it, and but we've identified it to be a normal variant. And let us see one case, and then probably we'll talk about all these things. So this is what we are seeing. This is a cavum vergae, which is an extension of the sort of a fluid-filled space posterior to the cavum septum pellucidum. But the only part is this, that we are seeing it at 27 weeks, which had given some sort of an some jitteriness or some sleepless nights to the parents, and then we identified that probably this is a normal variant. What we could have looked around for is the direct and non-direct signs for an absence of corpus callosum. So now this is what we are seeing as a direct corpus callosum. So in full length we can see the corpus callosum. So this is a direct signs in which we are seeing the corpus callosum, and non-direct signs are also very very important, which we can have a colpocephaly, which is meaning there's some prominent of the occipital horns and an high riding third ventricle. So if the direct and the non-direct signs for the absence of the corpus callosum are not there, we identify it to be a normal variant, and it is very very reassuring. Okay, as we've identified that this cavum vergae is a normal sort of an anatomical variation. Usually, it starts to obliterate starting from 24 weeks onwards. It was slightly unusual for this cavum vergae to be seen at 28 weeks. And but for all practical purposes, since the brain structures are absolutely normal, the corpus callosum has been looked around very well, and then the posterior fossa to the brain of the fetus is also being looked around, and absolutely everything is great. What we can expect it to get obliterated usually gets obliterated from posterior to anterior, from backward to anteriors, and therefore the anterior part of this sort of an CV or cavum vergae would be the last thing to get obliterated. And many times we identified it to be sort of an not obliterated and present at the time of birth also, but this is a normal variant. And reassurance is the sort of a word which goes out with this. Similarly, is the arachnoid cyst. Arachnoid cyst also in midline, small midline. Usually at the apex, we can identify that a fluid-filled space between these two membranes. And only thing is that probably we can keep a note of it, and therefore we can keep on them. No further ultrasounds, no all. So we'll make a note of it, and then probably we'll try to look around whenever we are doing serial ultrasounds. Probably we'll try to look around a note of it, and therefore we try to just follow the size of it, and absolutely. So in both these things across, it is only the reassurance is required, and nothing major.